So what we're going to go ahead and do is just dive right in. I'm going to introduce our speaker, which is Al Killian-Harvey. Al is the lead trainer at the Chadwick Center for Children and Families at Rady Children's Hospital on the California Screening, Assessment, and Treatment Project, which is a federally funded grant designed to improve trauma-informed care and child welfare and mental health systems across the United States. As a licensed clinical social worker, he has worked for over 2 decades in the field of trauma treatment in the Chadwick Center and served in the supervisory role during 10 of those years. Mr. Killian-Harvey is also the co-founder of the Harvey Institute, which is a training and consultation organization whose mission is improving healthcare outcomes through integrated sexual health principles. All right, Al, there you go.
Great. Thank you so much, Jared. And welcome to everybody. Very excited to be here with you. And again, our apologies for the little technical hiccup there. But as it often happens in trauma treatment, there are many unexpected things that come our way. And the key is to be able to bob and weave and flex with them. And that's what we're going to do today. I'm really excited to be talking about the importance of adding a trauma-informed lens to our assessment process. Just very quickly, in terms of historical context, the Chadwick Center is a child advocacy center here in San Diego, and as such provides an array of services to youth and their families who have experienced some sort of trauma. As such, we have been very focused on the avenue of integrating and incorporating trauma into all of our services. And so I'm excited today to talk to you about the time and energy and expertise that we have lent to making the assessment process one that also integrates trauma into it. So we're going to find out, first of all, who we have on the call now that we have an ability to communicate with all of you. And Jared, I'm going to turn it over to you for a poll.
Great. So the first poll question that we have is, what service system do you work in? So we're going to open up the poll question and go ahead and make the response. And you can see it's multiple choice. A, child welfare, B, mental health, C, juvenile justice, D, public health, E, housing, or F, other. Let's go ahead and take a second to check which service system you work in.
And please don't type this into the chat box, but actually click on the poll question that's popped up.
Okay, so we're going to go ahead and broadcast those results. And it looks like most of you on the webinar are represented in mental health, followed by, looks like, housing. Then after that, child welfare, which is great.
Super. Thank you so much for doing that. That really gives me a flavor for who we have and how to sort of tailor some of the remarks I want to make for the short period of time that we have in front of us. So let's begin by I posed a question to myself when I was preparing this and to all of you as well. What is the importance of adding a trauma-informed lens to an assessment? Every organization, every mental health or social service organization or agency has some form of an assessment. We all have some entry point into our system that we've developed over time. So why is it important now for us to think about, is trauma embedded within that? Have we made a concerted effort to make sure that what we're asking and what we're exploring has a trauma lens to it? For me and for our organization, amongst the many reasons why we thought this was an important area to focus on is, first of all, we now know, even though for a long time I think many of us were in denial about it, we now know that many, if not most, of the youth that we serve, no matter who our organization or agency is, may indeed have some history of trauma. Conservatively, estimates say 1 in 4 girls and 1 in 6 boys have experienced some sort of sexual trauma. And that's just one aspect of a traumatic event. When we expand that to exposure to domestic violence or family violence or community violence or other traumatic events, then the numbers escalate. So first and foremost, the youth that we're serving, even if that is not the direct outreach for our organization or agency, probably are entering our system with some sort of traumatic history. A second component that we realize is even organizations that in the past have focused on youth that they perceived or knew had trauma histories, there's been oftentimes reluctance to welcome that into the conversation even at the beginning. It became very oftentimes sort of the elephant in the room. We thought it would happen. We thought it was part of our youth experience. We might have heard about it, or it might have been in written form somewhere, but nobody was actually directly asking about it. Clinicians were waiting for the client to bring it up. Client was waiting for the clinician to bring it up. And so what we really want to emphasize in today's talk is the importance of making this an explicit part of the conversation. And we'll talk in a little bit about some of the fears that have been present about bringing that into the conversation, and hopefully provide some rationale for why we really need to move forward despite our fears of really bringing this into the discussion. The last piece that I'm going to focus on throughout today is also the context. We're going to talk about the substance of asking and the forms in which we ask these questions in an assessment, but we also want to consider the environment, the ways in which we're asking. Where are we? How are we set up? Where is the youth or the family member when they're answering questions? Is that also trauma-informed and trauma-sensitive? Many times we find this is where the most egregious violations of the trauma-informed lens occur. The questions were asked, but they were asked in a place that felt unsafe for our youth, or where our youth weren't quite sure what was going to happen with the answers. And when you come from experiences of trauma, these kinds of issues become vitally important, is making sure that there's indeed some sort of emotional and psychological safety. So let's take a look further at the core components of a trauma-informed assessment. I'm going to start first with a phrase that we developed here at the Chadwick Center called the concept of the unique client picture. This will really become the kind of overriding umbrella theme for everything else that we talk about in the assessment. We believe, our experience has been here at Chadwick and in working with community partners throughout the state and actually nationally as well, that each individual brings to a traumatic event many unique and personal characteristics. While the traumatic events may be similar, the traumatic responses are almost always universally unique. And so we need to recognize that the client that's sitting in front of us brings with them a history, a family history, a cultural history, a community history, an interpersonal history that is going to influence how they may have responded to whatever traumatic event it is that was present for them. For some individuals that may seem pretty obvious, but the reality is that we oftentimes people find clinicians and organizations and agencies short-circuiting this particular concept. We hear somebody has been exposed to physical abuse, or was in a home where there was domestic violence, or experienced sexual abuse, and we already go into a kind of a mode of, well, I can predict how they're going to look and how they're going to respond, and therefore I already kind of know what kind of treatment I want to provide. That is not actually providing a trauma-informed assessment for this individual. We've already decided who they are, how they responded, and what they need. So this unique client picture reminds us that we have to stay present with the client who's in our office right now. And we need to be asking questions that help us fully understand who they are and how they responded. The next components on your slide excuse me, provide sort of the foundation for the rest of our talk. We're going to talk about taking that assessment and breaking it down into several components. The interview and behavioral observations, the standardized assessment measures, and then bringing these together in what we call the case conceptualization and treatment planning. And then we're going to tie it together by the importance of talking about client feedback throughout the process.
Yeah, I like my
So this concept of the unique client picture, what you have in front of you at this point is a maybe somewhat hard to read. We are going to give you a reference at the end to a resource guide that has this and several other things incorporated into it. So if this is difficult to read at the moment, we will give you something else where you'll get to see it a little bit bigger than what is presented here. But this is a pictorial description of what this unique client picture looks like from our perspective. So it starts with this behavioral health assessment that we're talking about today, and it says that within that, there need to be certain core areas that are explored and questioned with our clients in front of us. Symptom presentation, medical and developmental history, trauma history, involvement with social services, family functioning, contextual and environmental history, which also includes cultural history, and child and family strengths. These become the pillars by which we begin to understand who is the client that is present in front of me, what has their experience been, and most importantly, what do they need to receive in order to move forward from the experience that they've had. All avenues should be explored in this unique client picture. That is really fundamental to a trauma-informed assessment process, that we don't skip any one of these. Each of these is as important as the next. So now we're going to guide you through a little bit of some of the ways in which we suggest that you touch upon these themes. Now we're looking at this concept of the assessment process, and we're going to break it down into three key elements: the clinical interview, behavioral observations, and the standardized assessment measures. Those are the three sort of components that we most want to focus on in moving forward. So let's begin with the clinical interview. Again, almost every organization or agency that I've encountered, that I've worked with, that we've worked with here at Chadwick, has some version of a clinical interview. What's interesting, when you talk to people about the clinical interview, the initial portal through which our clients come to seek our services, it's fascinating how when I ask individuals, what's the overall theme? What are you trying to achieve here? How was this interview process set up? Many individuals, depending on how long they've been in an organization or an agency, have a really difficult time answering that question. What's happened is, as part of their orientation, they've been given a set of questions that the agency or the organization says we ask. What we find many times is those questions have changed over time. Questions have been added, other questions have been taken away, there's been revisions, but oftentimes that's been done in a piecemeal format. Never with a sort of let's pull back from kind of the 1,000-foot lens and look in its entirety. Does this process really do what we want it to do? Does it tell us who this individual is, and does it lead us most specifically to the appropriate level of treatment? Trauma-informed assessment allows us an opportunity to really kind of look at these systems in that broader scope and revise them accordingly. We suggest in the interview process of trauma-informed assessment that first and foremost that questions should be asked specifically around traumatic events. Again, for some individuals this may seem obvious, but oftentimes for many organizations this is actually skipped. Again, we wait for the client to bring it up, or we stumble upon it later on in the course of treatment, but we never actually asked from the beginning. Some of the myths and stereotypes that we often hear from individuals is, I'm afraid that if I bring it up, then I'm going to further traumatize the child or the family members. Maybe they don't want to talk about it. Perhaps they had experienced a traumatic event and they're actually okay from it now. Why bring it up for them again? I will only risk the possibility of doing harm instead of actually helping them. And what we've actually found with clients is the absolute reverse of all of that. The harm, the risk, the minimization around trauma happens because we didn't ask about it. So now the client is sitting with the feeling, the clinician is not asking, the assessor is not asking, the elephant is in the room, and now I feel even worse. So now I'm not going to bring it up. So either I'm not fully engaged as a client, or my needs are not going to be adequately met because you don't actually know what's happening for me. So trauma needs to be called out specifically, and we'll give you some suggestions in how to do that as well. In doing that, we do suggest, however, that you move from the general to the more specific, that you don't start right in. Have you literally experienced some sexual abuse by a partner in your life? That's a very specific question about a traumatic event. That's probably too much, too soon, too early in the process with somebody, depending on the nature of the organization and the ways in which you work with your clients. But there are ways to go from the general to the more specific, and we suggest that in looking at your interview protocol, your standardized interview protocol, does it actually titrate that way? Does it go from engaging questions, more general questions, questions to get general feel for the client, to a little bit more specific about their experiences? That is context. Now let's talk about the overall kind of environment in which this happens. Where are you asking these questions? How are your office spaces or interview or assessment rooms set up? Are they friendly to youth, to adolescents, to young children? Do they have things in that may help somebody who, in the course of needing to talk about a traumatic event that happened for them, has some safe place to go visually? Are there things in the office that can be overly distracting for our clients? Many times we add actually too much stimulation to our interview rooms, and our clients get overwhelmed. They may be flooded with reminders around the traumatic event, and now they're also flooded by the stimulation that's in our office as well. So think, as you're considering where it is that you engage clients in these interviews, think about the environmental factors that may be at play there as well. We really encourage the concept of allowing the client as much as possible to be in control. Now, there are going to be limitations to this. There's always limitations to control. All of us would love to have full control over everything, but the reality is that we don't. But for clients in particular that have trauma histories, control becomes an absolute imperative. Trauma, in and of itself, the definition of trauma is that something happened that I had no control over. So it makes sense that individuals that have experienced that have an even stronger need than most of us do to try to have as much of a sense of control over what happens moving forward. Because the fear is, if I'm not in control, then something bad's going to happen again. I'm going to get hurt again like I did before. Think about that when you think about the ways in which you engage your clients in a clinical interview. Minor things, seemingly minor things to us, may become very significant to the client. Something as little as, which chair do you want to sit in? Where do you want me to sit? As I'm going to talk to you about these sorts of questions. Things like letting a client know how long the process is going to take. This usually takes about 45 or 50 minutes. I want to let you know that. Or when the big hand is on the 12, that's when we're going to stop, depending upon the age and the developmental level of the client. There are ways to adapt to this. But letting them know so that they can predict a little bit. Unpredictable and not in control are really, really dangerous sort of terms and feeling states for clients that have experienced any kind of trauma. So trying to maximize that in your interview process can be really, really important. So now let's go to the next element, which is behavioral observations. This is really what I call the clinician's gut feel. So we have your standard interview protocol questionnaire that your agency has set up for you, but we know that most of us don't rely just on what was said on that piece of paper, just on the answers that the client gave to those questions. That we're also observing. That's part of what we get trained to do as assessors, as clinicians. We're looking at, we're observing what's going on in the room. That gut feel is important. We really encourage you not to discount that. Who sat where? What happened when certain questions were raised? Did eye movement all of a sudden change? Did body language change? Did the positioning of the clients in the office rearrange? Did all of a sudden everything stop? What was it like? What did I just feel in my gut when they said a certain answer to some of the questions that I asked? That's the clinician's gut feel that I think is as important as these other pieces that we were talking about today. However, and this is the other piece, we shouldn't rely strictly on that gut feel. And we've often found individual organizations where that's been the case. I've done this for so long. I know how to read a client. I don't need a questionnaire. I don't need assessment measures. I don't need the rest of that. I've done this work enough times that I know how to do this. Just that gut feel alone can be dangerous. We can, as we know, we can be caught in our own countertransference issues sometimes. It may be our projections onto the client, but not actually the client's experience that we are responding to. So it's a very interesting sort of middle ground that we're suggesting that you really straddle here, which is to be aware of your gut, but don't rely solely on the gut feel. The next element that I want to introduce is this idea of standardized assessment measures. This is a key component of what we advocate for in a trauma assessment protocol. We have the clinical interview, the standard protocol interview that your organization has set up, your gut feel, kind of your intuition as a clinician, your sense of what's happening. And now we really encourage you to explore the possibility of integrating, if you don't already, standardized assessment measures. These are often, my youth that I work with, the young folks that I work with often call them tests, so I really try to discourage that term, but they look like that to them. So it's a questionnaire that's developed. A series of questions are asked about some aspect that we are trying to explore as part of our assessment. These questionnaires, these standardized ones, have been standardized and checked for validity, reliability. So you don't want to just use random questions that somebody's come up with. You want to make sure that they are actually evidence-based and have science behind them. Some organizations are using standardized assessment measures as a complement to their assessment. Many organizations and agencies still do not. We're sort of curious at this point about whether or not these are used for you. So, Jared, we have another poll question for folks related to standardized assessment measures.
So the question is, and you should have a box opening up on your screen to respond, is do you use standardized assessment measures? A for yes, B for no, or C for unsure? Go ahead and take a second to respond. So getting some responses. So, okay, it looks like we're going to go ahead and close the poll and broadcast the results. So as you can see, the majority of you, by a lot, use standardized assessment tools at 65%.
Great. That's super. Thank you so much. And that's really good news to hear. I think had we been doing this webinar even 3 or 4 years ago, I think that number would have been decidedly different. I think this has been one of the more interesting, innovative sort of changes we've seen in the arena of assessment in general, and certainly in terms of trauma-informed assessment, is that we now know we have some reliable tools that can complement what we're already doing. And again, I'm going to overuse that term maybe a lot, but this is a complement. This is not a piece that should be used in place of or instead of the other two pieces of this overall figure that we've been talking about. Still, the protocol questionnaire, the initial intake questionnaire is important, the gut feel is important, but the standardized assessment measures are a complement to all of that. So, most of you already use these, so I'm going to move through this pretty quickly, but for those of you that don't, I just want to highlight a couple of areas as to why this would be important. It helps us to using these standardized assessment measures help us really gain a lot of information in a short period of time. That's one of the key components of it. We know, those of us that do this work, when we ask questions of clients in a traditional sort of way, sitting in the room, tell me about this, tell me your history on that, have you experienced this? Sometimes one question may take 30 minutes for a client to answer for us. Depending upon our skill set, depending on whether or not we can help a client kind of consolidate that answer or not, or whether or not we want to. Nonetheless, the reality is that those kinds of questions, those open-ended questions, can take quite a bit of time. That's important for engagement. It's important information. But sometimes what ends up happening is because of time constraints, we then end up not being able to ask a lot of other questions that we really needed information from in order to assess who this client is. That's where standardized assessment measures come in handy. They are usually quick, they can be completed in a quick period of time, and yet they cover a variety of pieces of information that if we were to ask in the interpersonal sort of one-on-one dynamic with a client could take a lot more time than we really realistically have time for. The other component that I really want to underscore, which I think is part of what actually sold me, quite honestly, to do personal disclosure, I was really reluctant to do this. I really saw standardized assessment measures as sort of an obstacle. I didn't need those. I covered that material already. Why do I have to have something else that does this for me? Two things about it is I have found over time, and we have found over time, that sometimes people answer things differently when they're asked in a written form than when they're asked in a verbal, in the moment, with another person form. There's something about looking somebody in the eye and answering a particular question, and maybe feelings of shame that somebody has, feelings of embarrassment, that I don't want to acknowledge something to you because you're sitting right there and looking at me. But if it's on a piece of paper, it's a little less personal in that regard and may free me up to be a little bit more honest about what's happening for me. Sometimes, actually, we think we've asked the question, but the way that we framed it, the client didn't actually hear it that way. But when they see it on a standardized assessment measure, oh, that's what was being asked, and therefore the answer may be different. So the use of standardized assessment measures actually brings in, many times, pieces of information that really can't be gathered in our more traditional ways of asking. And I think they're a great resource. We are going to give you a link at the end to a resource guide for a trauma-informed assessment process. And there's an appendix in there, Appendix F, that really talks a lot more about standardized assessment measures and even gives some suggestions on some of the ones that might be helpful in creating this more trauma-informed assessment process. So the assessment pathway process would be to administer these standardized assessment measures. Trauma-specific ones is what you want to be looking for as well. Many of us are familiar with more general assessment, standardized assessment measures like depression inventories, etc. But child trauma screening questionnaire, for example, is one very specific trauma-focused assessment measure. Problem areas are identified as a result of that, and then many times what we'll do is we'll add a few more assessment measures to the mix. Okay, so I've gotten more information that I didn't get before. When I try to put that together, it maybe doesn't clarify the picture, it actually raises more questions. Gee, I didn't realize that the client was having intrusive thoughts in the middle of the night. Might that be something that I need to ask more questions of? Is that maybe related to the traumatic event that that particular client experienced? So all of this is done in order to now develop what we call the case conceptualization. So we take the results of the standardized questionnaire, the standardized assessment measures, and the gut feel from the clinician. And we put that all together to try to give us this unique client picture. So who is this client in front of me now? What have I learned over the course of asking these questions in these multiple ways and in sitting with the client when asking these questions in multiple ways? So the case conceptualization really summarizes all of those highlights. It should be looking at both strengths and challenges. Again, a key component we often see neglected. The clients are only asked the areas that cause them trouble or challenge or dysfunction in some way, and we don't pull for their strengths, which are going to be vitally important in the treatment planning. And all of this is done in order to then tie to the treatment plan that we have in front of us. There should be a clear connection between those. Some quick, again, in our resource guide, Appendix G will show you what one version of what we say a case conceptualization might look like. And here are some of the areas that are on that particular one. There's many more as well. But it covers things like the risk assessment, the trauma history, the physical health, the sexual health, the caregiver and parent and consumer engagement. These are just subcomponents of that conceptualization. So have I looked at all of those? Have I assessed all of those? Have I seen the strengths and the challenges of all of those? And now that unique client picture, what does it tell me? What do I need? What does the client need? And how do I move forward? The last piece that ties this all together and should be a part from the beginning is the concept of client feedback. This should be true in any assessment that we do in any organization or agency, but in particular with clients that have experienced trauma. We want to make them a part of the process from the beginning. Remember, at the beginning of today's talk, I mentioned this concept of control. This is one of the ways to reinforce that concept. This is your treatment. You're coming here because there is something that you need or want from us, and so we need to make sure that you're getting what you need. Going through the results of your assessment all the way through, does this match with you? Here's what I'm starting to learn about you based on how you answer that question. Here's what those measures start to give me a picture of how you responded to those events. Does that match your experience? Am I reading that right, or am I not? Those are the kinds of questions that you want to explore with your client to engage them in the process, to let them know this is really yours. You need to be driving this, not me as the clinician telling you what to do. We want to make sure that the treatment plan, therefore, is something that everybody is fully engaged in. A treatment plan that, for us, looks perfect and it addresses all of the issues, but that a client doesn't buy into, we know where that leads. 2-3 sessions and the client is gone because they sense this is about the clinician and not about me. So actively engaging in that feedback loop is vitally important to what we do. So overall, what we've suggested here is that we believe that if you have those 3 components of your trauma-informed assessment, the standardized questionnaire that you have, the evidence-based standardized assessment measures, the gut feel, creating this case conceptualization or the unique client picture, which leads to the treatment plan, will lead to better treatment outcomes over time. That has been our experience. That's what we believe is true. want to talk just a little bit, with just a couple of minutes that we have at the end here, about, I gave you just a very broad brush kind of overview of some of the key components of a trauma-informed assessment plan. We at Chadwick have had the ability through several of our grants to work with several counties at a macro level, this is more at a macro level, at trying to integrate these into their overall assessment. I think some of the things that we learned at that macro level apply it in any organization or agency, whether it's a social service agency, an individual private practice, a school setting, a county child welfare or behavioral health organization. The key thing we found first and foremost is that there has to be buy-in from the top. Leadership has to believe that trauma needs to be an integral component of any assessment that we do in our organization or agency, even if the overall mission of the agency isn't necessarily trauma specifically. But this needs to be addressed because it plays out with almost every client that we know, that we work with. Early and consistent involvement at all levels of the organization in developing and revising the assessment protocol has been crucial. You need to have a variety of voices at the table from the start. Not just kind of a couple of leaders who say, okay, we're going to change our assessment or broaden our assessment to be more trauma-informed, and then impose it upon everyone else. Everybody from the top down should be involved. IT becomes very important depending on the size and scope of your organization. Many times our assessments now are driven by the technology, and there may be limitations for that technology, and we need to know that up front, or there may be actually ways that the technology can enhance and expand this trauma-informed sort of method that we're suggesting. So IT, important part of the conversation. And setting realistic, clear, and achievable goals moving forward. True in any project, but certainly with this one in particular, many times what we have found is organizations and agencies have really kind of were shooting for the moon right from the beginning and then felt very frustrated because they couldn't get there right away. So you want to test small amounts of change, small periods of time, see how they did, and then try another aspect of change over time as well. So very quickly, I've taken you through just some fundamental components we believe are important in this trauma-informed assessment process. As I mentioned to you, we do have a resource guide that is available to you. There is a link that you're seeing now on your screen where you can access that. We also have, for a short period of time left under our grant, an opportunity for a couple of counties. This would be more at a macro level. If there are folks on the call that serve in any kind of leadership or supervisory and managerial positions in our counties in the state of California that would be interested in just a couple of calls over the next 6 to 8 weeks to help guide a little bit. You're looking at your assessment protocol and seeing if it's trauma-informed or can become more trauma-informed. We do have an ability to provide some technical assistance on that. I've given you a contact person here at our organization, Megan Platt, who'd be happy to talk you through that process as well. So with a little bit of time that we have left, I'm going to turn it back over to Jared and see if we've got some questions from folks.
Great, thanks, Al. So just a reminder, if you have any questions, feel free to submit them through the Q&A pod, and during these last few minutes, we can read them out to Al. But in the meantime, we do have some questions that we can ask Al. So first is, aren't standardized measures an impersonal obstacle when trying to engage clients in treatment?
That's a great question. We often get that question. So I'm sitting there, I'm working very hard on my engagement skills. I'm trying to connect with my client. Body language is so important. Eye contact is so important. Being culturally sensitive to where the client comes from is so important. And then I stick a piece of paper in front of them and say, answer these questions so I learn more about you. If that's the way that standardized assessment measures are delivered, yes, that's an obstacle to our treatment. But we really, really encourage, if folks are using standardized assessment measures or considering them, that actually the ways in which they are disseminated and used with the client can enhance the engagement process, not become an obstacle. What we want to do is we want to explain why we're doing that. I've asked you a bunch of questions, and it may seem sort of crazy that now I'm going to give you a bunch of written questions as well. You know, that may feel like a lot. Let me tell you why I'm doing that. I'm doing that because we really want to make sure that we understand who you are. We really want to make sure that we understand whatever happened to you is what we're addressing here so that we can help you feel better about what went on. And we think that these additional questions are another way for us to learn about that. that can be a part of that engagement process. And again, remember our component of feedback being important as well. What you also want to say to a client before you stick any kind of piece of paper in front of them is, and we're also going to tell you what the results of those questions are. When we look at your answers and kind of summarize them, I'm going to tell you what I think it says to me to make sure that it matches what you really believe it says as well. So as opposed to being an obstacle, they can actually enhance the engagement process.
Great. So we do have another question coming in. Is the PTSD assessment a sufficient tool to use for assessing trauma, or is there a difference between a PTSD assessment and a trauma assessment?
That's a great question, and a really complex sort of question. But if your organization or agency is using a PTSD assessment, that's awesome. So what that says is that at some point in time, your organization realized something specific about trauma needs to be incorporated into the ways that we ask our potentially new clients about what their experience is. So that is one component. Now, is that sufficient is an interesting question. That would take a lot more understanding of your organization, your agency, and the clients that you serve. But that's a great question to start asking of your staff members, and maybe even asking of your clients as they're about to exit the treatment. Do you believe that we knew enough about you going into this? Do you believe we asked the right kinds of questions about who you are? So what you might find is the PTSD assessment really was a good starter point, but now we realize that maybe we want to add another piece to that as well. There will always be this juggling act. There could be 1,000 different standardized assessment measures that we give to clients. I mean, the more measures we give, the more information we get. That's a great thing, right? But the balance is that we can't do that. We only have so much time. There is, only so many questions being asked of a client before it's overload. So you're always trying to balance how much information to ask before it's too much, but how to make sure that we're asking enough so that we know who the client is. And for every organization and agency, that balance is going to be slightly different. But I applaud you for at least already beginning to think about that and understanding that that's an important piece of your assessment protocol.
Okay, I know we're going a little bit longer than what was advertised for the webinar, but we do have some additional questions coming in. So Al, if it's okay, I can run them by you.
Sure.
So we have one coming in. Are you also using resilience measures?
Really great question. This is the hard part about doing a webinar, first of all, and a webinar that is so short, covering such a large topic. So we didn't even touch upon the concept of resilience. It's implied a little bit when I mentioned several times the importance of looking at strengths, and resiliency is a strength. Yes, absolutely. I think it's definitely important for organizations and agencies to be pulling for strengths wherever they can, resiliency being one of those. Interesting thing about resiliency is that, there is still some controversy around that. Can it be quantified? Do we know exactly what it is? Do we know how to ask about resiliency? There's still not universal agreement on even what resiliency looks like. But the importance of looking at, do we understand how clients respond and bounce back from things and what strengths they have is vitally important. So yes, I would say if you're using any kind of instrument that is pulling for some degree of strength or resiliency, that's a key component here.
All right. So we are getting questions about certificates of completion. Just to let everyone know, those will be emailed out along with a link to a survey.
It'll be at the end of the survey once you complete it.
Right. Okay. Folks are typing. Great. So we're going to go ahead and close it out. Thank you, everyone, for joining today's webinar, and thank you so much to Al for presenting today. And if you have any questions, feel free to shoot Al an email or to the CABC. And thank you so much for joining us, and apologies for the technical difficulties.
Have a great day.